right, welcome back. Hopefully we've conquered the video delay issues. Wrong button there. Okay, so hey folks, for those of you that were there for our opening special plenary, hope you enjoyed that talk. Again, sorry for the little technical glitch in terms of the video audio delay. Our next session is actually fully live, so hopefully that is not going to be an issue here. Here's some disclosure information. This can also be found on the Meeting Hub page. And run through that. So the annual Meeting Hub, hopefully all of you have been there by now. This will be the route by which you claim CME credit and MOC points. And for more information just about learning opportunities with ACP, that's there. So Matt Holland, current governor for the Washington chapter of the American College of Physicians. I give everybody a warm welcome really across the state, joining us in this virtual chapter meeting in these up and down times. Hopefully today in this meeting and the opportunity to see colleagues in the AirMeet platform gives us a little sense of the normalcy that we hope to return to. Really appreciate you all being here. I'm going to run through a few quick kind of AirMeet points here. If you have really like everybody else is hearing, but you can't hear or something like that, and platform questions, we have the purple question mark there that takes you to AirMeet support. Importantly, this function, there's two distinct functions. There's a chat function here that allows you to communicate with either individuals or with sort of all of the attendees. That's separate from the questions. So if you have questions for the speakers, we want you to use this, this question icon here. Click on that. And that actually, the questions get posted specific to the session, and so we can handle them that way. If you haven't figured it out by now, we have all different kinds of tables where you can sit down and interact with your colleagues. There's table chat, and in breaks you can have conversation with them. And there are over 30 tables. Again, here's the virtual Meeting Hub. We're going to highlight two things here. We do have a passport program. Again, this year, there are 4 passcodes. There are 3 exhibitors on the wellness table. If you go to all of those, they'll give you a passcode, and then you can submit your exhibitor passport through this tab here. And you're entered into a drawing if you are a full member for an Apple Watch, just like prior years. And if you are a resident or student, a Fitbit, and we'll announce those at the end of the day. We also have some small gifts for people that complete bingo, and you can, if you get a bingo, put it in your chat. And those are basically just listen to the talks, and if something's mentioned in a talk, cross out the square that has that mentioned. So again, connect throughout the day. As you saw back on this prior slide, our CME on the go recordings are there. Do know that for the MOC questions, some of them are based on the CME on the go, so you will want to watch those. Please join us on Saturday, more about meeting evaluation. I talked about visiting the exhibitors and the wellness table. I want to highlight, please, we really want to encourage folks to use the hashtag WASH-ACP 2020, and I am proud to highlight your favorite highlights. Will be and then tag us at @WASH-ACP, so we'll be putting those forward through the day. And then again, at the end of the day, we'll do a quick summary of the day. We'll announce passport winners. We'll also announce for those of you that registered prior to last Monday, we'll announce the person who gets the free registration in 2021. So We could not have done this without our amazing co-chairs, Dr. Leah Marcotte and Dr. Anna Hagen. And so they'll take us through much of the day. And Dr. Anna Hagen is shortly going to introduce what I think will be what is always an absolutely amazing session, and obviously particularly relevant this year. Dr. Hagen will introduce our first speaker on a public health update. And before we do that, we also have story slams this year, and so we're going to now segue into our first story slam, and then that'll be followed by Dr. Hagen's introduction. So let me just get out of there. And we're ready for our first story slam.
Good morning. My name is David True. I'm a primary care internist and provider of care in skilled nursing facilities for Pacific Medical Centers in Seattle. I wanted to thank the organizers of our Washington chapter meeting of the American College of Physicians for selecting my story for today's Story Slam reading. My piece is entitled From Frontline to Quarantine. The North Queen Anne nursing home I visit regularly is even quieter than usual. A staff meeting lets out, and I see many I know with tears in their eyes. As they help each other don gowns, one says to me, "I wish that it would all just be over." Later, I learn the meeting announced the pending withdrawal of life support for a colleague hospitalized and on a ventilator with COVID-19. For 26 years, I've provided care in nursing homes, normally a space buoyed by holidays and birthdays, volunteers playing music, and visiting pets providing love. Now, loved ones can only hold up signs or talk on cell phones through windows. My entry into this new and strange world was abrupt. I was at the Life Care Center in Kirkland on February 26, 2020. At the Life Care Center, I first noted concern on the faces of nurses reporting fevers in several patients. Influenza tests came back negative, and I commented to my colleagues how odd it was to see a cluster of patients with fever and respiratory symptoms without an influenza outbreak. 2 days later, the patients admitted to Evergreen Hospital tested positive for COVID-19, the first known outbreak in the United States. 43 residents of Life Care died within the next month. I isolated and quarantined beyond the 14 days required, feeling restless and lonely. I gave up salsa dancing for walks and bike rides and cross-country skiing alone on empty trails. I used the solitude to write about my experiences caring for patients, an increasingly important way to articulate my feelings of loss. Isolation and quarantine represented a reversal in my role. Now I was the one being shunned for fear of contagion. As I become more empathetic to the loss that patients and their families experience regularly, it feels similar to the collective soul-searching our communities engage in around the recent murders and long-standing injustices suffered by people of color in our nation. We are broken open to see new realities we've always lived close to. My hope is this newfound awareness of others' struggles doesn't close back up entirely, so we might remain more compassionate and fair to those we walk alongside in this world. Thank you.
I would next like to introduce Dr. Jeff Duchin. Dr. Duchin is the Health Officer for Public Health, Seattle and King County, and also serves as the Chief of the Department's Communicable Disease Epidemiology and Immunization Section. As Health Officer, Dr. Duchin is the key science advisor on program and policy development and provides leadership in developing priorities and setting strategies for the department's work. He also holds appointments at the University of Washington as Professor of Medicine in the Division of Infectious Diseases and Adjunct Professor in the School of Public Health. Today, Dr. Duchin will be providing us with a public health update, health system response to an epidemic.
Hey Jeff, sorry to interrupt, but you are actually muted.
How's that? Can you hear now? I'll just assume you can. So thank you for the invitation. I titled my talk a couple of months ago before I knew what to expect or whether I'd be able to even do it. And it's not going to deal only with the healthcare system response. It's going to provide a bit of an update with some important points from my perspective, and also set the stage and hopefully help us move forward more effectively. So, setting the stage, back in January, China identified this new virus that, according to Chinese authorities, could cause severe illness in some patients, but doesn't transmit readily between people. And you'll see throughout my talk that there are some key communication points that have hamstrung our response in different ways. Shortly thereafter, we had our first case in the United States detected in Snohomish County, and you can see from the expressions on the governor's face, the Secretary of Health, John Weisman, and our CDC colleague, Satish Pillai, that despite the advice the public should not be panicking right now, there was a very high level of concern. And very shortly thereafter, teams were mobilized to retrace the steps of our first case in Washington State. And it's important to point out in that context that at that time, the patient was believed to be communicable and able to transmit only at the time that symptoms appeared. So, as quoted in the New York Times, the Snohomish Department of Health team said they plan to remain in daily contact with those who are around the patient to monitor for symptoms, but have not asked them to isolate themselves under the assumption that this variation of coronavirus, which researchers are only beginning to understand, operates like other versions that transmit only when someone becomes symptomatic. We subsequently have learned that's not the case. However, in this investigation of the close contacts of that first case in Washington State, we were able to test, we're using PCR and serology in almost half and PCR in 2/3 of these close contacts, some of whom had face-to-face. There was no one who was positive. Now, of
Hey
course,
Jeff, sorry to interrupt again, but I think you need to share your slides because we're not seeing them.
oh man, share my slides. Let's see. So I need to start over, huh? Okay. Share my slides. Let me find my share. Can you remind me where the share slide function is?
Yeah, of course. It's just going to be at the bottom where where you control your mic and camera. It's like a little up arrow, and it says share screen. You got it. Thanks.
All right, let's try it again. Okay, so I'm assuming you heard what I said, so I'll just go rather quickly to catch us up. But the first case identified in January in China, and we were reassured at that time that the virus can cause severe illness but doesn't transmit readily between people. The first case in Snohomish County, which mobilized large teams from the Department of Health, the CDC, and local public health to investigate. The act of identifying the close contacts of the Snohomish County case, which were contacted and monitored, but were not asked to isolate because at that time it was not believed that the virus could transmit from people before symptoms developed. And the study that showed that none of the close contacts who were identified became positive. However, I was pointing out when I learned that you couldn't see my slides, that we were not able to identify those contacts who would have been exposed in the time the patient was symptomatic, but in the time the patient was not symptomatic, but still able to spread shortly before the onset of symptoms. And you can see here that exposure occurring on day 0, symptoms occur here. And then in the 2 days before symptom onset, virus levels become very high, and this is where we have pre-symptomatic transmission. It's estimated that 40 to 50% of transmissions occur in the asymptomatic or pre-symptomatic scenarios, and then viral load highest in the first day or 2 after symptoms, and then rapidly drops off. Now at this time, we are again quite concerned here locally, but we're reassured at the federal level that the coronavirus was totally under control, and this set the stage for the ongoing disconnect between what we were seeing at the public health and community level and what the federal government was telling us, which has hamstrung our response to this day. As of Wednesday, the U.S. reported over 100,000 COVID-19 cases, which is the highest single-day total on record, and the first time any country in the world documented more than 100,000 cases in a day. A few days after the president assured us everything was under control, the World Health Organization declared an outbreak, public health emergency of international concern. All the committee members, except for China, voted to do this. And at that time in the U.S., you probably recall that our entire focus was on incoming travelers, particularly travelers who had been to Wuhan, China in the past 2 weeks. This is how we were attempting to identify the introduction of the virus into the U.S. And I'm sure you're all familiar with the case definitions that we were using to establish criteria for laboratory testing. There needed to be the clinical syndrome of fever and lower respiratory tract illness, a relatively severe disease, plus a history of travel from China or close contact with a documented COVID-19 patient. But as Dr. True noted, on February 28th, the criteria changed. And now fever with lower respiratory tract illness and no identified source of exposure without another explanation were eligible for testing. And our colleague Frank Rito at Evergreen Hospital immediately sent a number of specimens to be tested, and the next day 3 were positive. And this was the beginning of our local outbreak. We were off to the races here. We had 1 death identified and 2 other cases that were linked to the life care facility in Kirkland. This life care facility became the epicenter of our local outbreak, and I'll share with you a little bit of information, some of the lessons learned from this outbreak. Oops. In a matter of days, additional cases were identified at the life care center, and on the 29th, when those results came back, we talked about what we might need to do to head off widespread community transmission. And on March 4th, 4 days later, we issued sweeping recommendations for residents to limit their exposure to one another and to avoid large gatherings in King County. And then 1 week later, the governor issued the statewide stay home, stay safe mandate, and we did similar restrictions in King County. At the same time, Life Care Center was progressing. So in total, there were 167 confirmed cases linked to the facility, including 101 residents, 50 healthcare personnel, and 16 visitors. And shortly after this outbreak was identified, within 2 weeks, we had 30 total long-term care facilities that had COVID-19 outbreaks identified. What's interesting about this particular facility was they had an outbreak of unexplained respiratory illness going on for 2 weeks before they contacted us at Public Health to let us know. And we don't know for sure, but we wonder how much we could have made an impact had we known earlier. We published our experience investigating this outbreak in collaboration with a very large team from CDC. And what we found, in addition to the delayed recognition, was staff members who are working while symptomatic. And I'm sure you know, regardless of COVID and even pre-COVID, long-term care facility members and other healthcare workers are not supposed to come to work with febrile respiratory illness. There were staff members who worked in more than one facility, and I'll share with you the implications of that in one moment. Inadequate familiarity and adherence to standard droplet and contact precautions and eye protection, with challenges implementing infection control practices, and inadequate supplies of PPE and other items. So this delayed recognition of cases was a combination of low index of suspicion, limited testing availability, obviously, for COVID-19, and difficulty identifying persons with COVID-19 based on signs and symptoms alone. And on that point, we did another investigation in collaboration with our CDC colleagues of one of the subsequent facilities where there was a COVID-19 outbreak. We had, at the time of the investigation, 64% or 57 of 89 residents testing positive for COVID-19. And among those who agreed to participate in a point prevalence survey, 63% tested positive, 48 residents, and of those, over half are asymptomatic at testing. And what this really drove home to us was that many residents with positive results in long-term care facilities and other venues can be asymptomatic at the time of testing and contribute to transmission. And therefore, our infection control strategies focusing solely on symptomatic people, which was what was happening at the time, were not sufficient to prevent transmission after SARS-CoV-2 was introduced. And so this led to the evolution of our now nationwide approach to infection control and recognition and testing of cases. This is the epicurve of long-term outbreaks by facility in King County. This is Life Care. And you can see within 2 weeks, we had 14 other facilities, and we were getting 10 to 20 new facilities reported every week through April. We implemented stringent infection control precautions, did on-site trainings and testings at these facilities, and the outbreaks started to decrease. But as you can see, they haven't gone away. And even throughout the summer, we're getting 8 to 10 outbreaks a week at times. And many facilities are having second outbreaks. What is somewhat reassuring, though, is that the number of cases associated with these outbreaks, and in particular with the secondary outbreaks, has decreased. The light salmon color here are employees, and the blue bars are residents. So with increasing knowledge of how to manage COVID-19 and increasing competence in using infection control precautions, the threat has decreased, but it remains very real. Now, I want to spend some time talking about transmission. This is huge. As you're all aware, this has been a big controversy, airborne transmission, and the Washington Post says it here, that CDC says airborne transmission plays a role in coronavirus spread in a long-awaited update after a website error last month. So this is one of the reasons CDC came to that conclusion. There was a choir practice in Skagit County, Washington in March, where one singer who had mild cold-like symptoms infected 52 of 60 other choir members, 2 of whom died. These people spent about 2.5 hours in their choir practice. They were rather distanced. They were taking precautions against COVID-19, yet in this enclosed airspace where a high-risk activity was happening, which is singing, we see that SARS-CoV-2 transmitted quite widely. And this is an example of a super spreader event that can occur in certain environmental circumstances. So I want to share with you now how we're currently thinking about airborne and droplet transmission. It's all in the context of what are called respiratory particles. And these particles can be defined as aerosols, which are the smaller particles, so less than 100 micrometers, and these can remain suspended in the air for hours, and it's best to think of these as like cigarette smoke, and that's how they move about the room, and they follow the prevalent air patterns and airflow in the room, and they would accumulate like cigarette smoke would in a room until ventilated out. And then these are the large droplets, the ones that were characterized as being responsible for most of the short-range transmission. These droplets drop to the ground within 20 centimeters or so, sometimes longer if they're expelled through sneezing and coughing. They can go farther like ballistic cannonballs, but they're heavy, they don't remain suspended in the air, and they're not responsible for long-range transmission. So when we are silent, we exhale relatively smaller amounts of virus, which accumulate over time. When we talk or speak, we emit 10 times the number we do when we're silent, which accumulate in the air over time. And when we do high intensity things like singing, shouting, and aerobic exercise, we emit 50 times the number of particles as we do when we're silent. And you can see they accumulate proportionally greater concentrations over time. So the current CDC website on how the virus spreads acknowledges that this virus spreads through respiratory droplets or small particles such as those in aerosols, as well as contact transmission, which is thought to be less likely, and that it is possible that these airborne particles that are formed when a person coughs, sneezes, sings, talks, or breathes can remain suspended in the air and be breathed in by others and travel beyond 6 feet. For example, during choir practice, in restaurants, or in fitness classes, all places where super spreader events have occurred. And it is critical to understand the importance of indoor environments without good ventilation that increase this risk. And if there's one point to take home from this talk today, it is think about ventilation in your workplace and in your recreational spaces and in your home. So here's a schematic depicting the importance of ventilation. These are meant to be these emitted microparticles containing virus. You can address them using portable air cleaners. Most effective is increasing ventilation through opening windows and doors or through HVAC systems. You can disinfect through air cleaning, through central HVAC filters, UV lamps, but recirculating air is a no-no because all it does is move the virus around and disperse it. So when we think about COVID-19 transmission dynamics, we have to think about the environment, factors such as ventilation, humidity, socioeconomic factors, which can all relate to viral transmission. Contact is critical. The duration of contact, the proximity, whether there's crowding, and what type of activity is happening. Talking, exercising, singing all increase viral excretion or viral load into the air. And then the source, the host. Not everyone is going to transmit to the extent that our super spreader did in the Skagit Choir. Some people put out a lot more virus in a form that can be airborne, and others put out very little. It's thought that 20% of people are responsible, 10 to 20% are responsible for the vast majority of transmission, and many people don't transmit to anyone. And then finally, what type of protection people are wearing. And of course, cloth face masks are critical for the general public, and surgical masks and eye protection for healthcare workers, as well as N95s when necessary. So in this same vein, I want to share with you this recent publication from MMWR on transmission of SARS-CoV-2 in households. And what we are studying here through a prospective study where household members completed symptom diaries and had daily PCR done, 101 households and 191 household members resulted in secondary infection rates of 53% of household members from a single case that became infected through their activities in the community. And what's noteworthy here is that the attack rate was very comparable among all ages in the household. And especially interesting was that less than half of the household members with confirmed infection reported symptoms at the time their infection was detected. And many reported no symptoms for 7 days after that time as well. So they were asymptomatic infections. And this underscores the importance of quarantine of people who've been exposed, because they can develop and transmit this infection quite readily without symptoms. In addition, I think an important take-home point is that the secondary infection rate from older children, 12 to 17 years old, was comparable to that from younger children. And there's a lot of speculation about how readily younger children can transmit. But in this study, children younger than 12 years transmitted as effectively as older children and adults. So the bottom line here is that if someone suspects they might have COVID-19, they need to isolate, stay at home, and whenever possible, use a separate bedroom and bathroom. And this is because prompt isolation is the most effective way to reduce transmission. Isolation should begin before seeking testing and before test results become available, and that should be part of your counseling message to your patients. In addition, other household members should wear a mask in the household, as should anyone who's gathering in the home with people from outside the household at any time, especially with the high rates of transmission we have in our community right now. And this is particularly important in shared spaces where distancing is not possible. And again, close contacts need to self-quarantine. So here in King County, this is a depiction of our contact tracing timelines. And the thing I want to point out to you is that total time is about 8 days from infection to interview, and less than half of the people that we contact are isolating themselves before getting tested, and 30% still are not isolating themselves after being tested before we contact them. So there's a lot that we can gain by emphasizing to people and patients the importance of isolating themselves with any symptoms pending results of testing, and quarantining whenever they're in contact with someone who may have SARS-CoV. And here's an example of why this is important. This is one family. Each color represents one family, orange, yellow, and blue, that went to a large multi-family gathering where someone had COVID-19. And at that gathering, 14 family members became positive. That's the circle here. These are the 14 family members, and they went and transmitted the infection that they brought back from the family members to grandparents, neighbors, to other couples that were in their so-called pod, to coworkers, to the parents of coworkers, to the children of coworkers, to the significant other of coworkers, and a healthcare provider transmitted to his or her patients. So the chains of transmission from these social gatherings can be quite protracted, and this is why we're seeing so much SARS-CoV-2 transmission in our community right now. So I just want to share with you the bubble you think you have with your few friends and family members if you're responsible. And if you're not, you probably have lots of social contacts and are contributing yourself to the exploding outbreak across the country. But the bubble you think you have isn't as tight as you think it is, because each of your contacts is doing all sorts of things that you don't know about, and their contacts are contacting others as well. So this is why we ask people to limit their contacts to 5 people from outside the household each week. Here's what's happening in the U.S. right now, closing in on 10 million cases, 250,000 deaths. We are responsible for the greatest amount of COVID in the world, proportional to our population, and we've done the worst job of controlling COVID of any country in the world. This is Washington State, and this is meant to represent the red color high rates of transmission, which is throughout most of the state at the moment. And you can see the early outbreak, the outbreak that occurred after Memorial Day and July 4th, and the outbreak that now we're seeing post-Labor Day. Here's a better close-up of what's happening in King County. So this was our April outbreak with the long-term care facilities and the stay home, stay healthy order. The outbreak was controlled quite nicely with the stay home, stay healthy, or the so-called lockdown, and rates dropped to a very low level, and then have been increasing as we reopened. July 4th, Memorial Day, led to a big spike. Came down again, and now after Labor Day and into the fall with COVID fatigue and the change in the weather, we're seeing record-breaking numbers of cases, over 300 cases a day this past week, which is overwhelming our team, as you can imagine. This shows us the age distribution of cases. We're seeing cases in all age ranges, but predominantly increasing in younger adults and middle-aged working age adults. The lowest increases and the lowest rates of disease at the moment are in our older adults, and the highest rates of disease are in our middle-aged and young adults, and increasing in children as well. And here you can see this is the same graph that I just showed you, but our test positivity rates are increasing, suggesting that the increases are not a result of increased testing alone, but increased transmission. And here you see the hospitalization and deaths. And although these graph scales are hard to see, you can see that we had a nadir in hospitalizations in the middle of September, and have had a very gradual and rather small increase in hospitalizations, but a definite increase since that time. These data are incomplete and should not be regarded as accurate. And then here the death counts also, this was a reflection of the age of the residents in the long-term care facilities and their underlying susceptibilities and higher mortality rates. And then as the outbreak started to affect younger people and people without the high-risk conditions, the death rates have come down. But again, you can see that since the middle of the month, we're on an upward trend, but still relatively low rates. And this is the 7-day rolling number of new hospitalizations among PCR cases in King County. And you can see, again, that slight rise, very gradual, but we're keeping a close eye on this. This shows the test positivity rates, the percent positive, and number of tests across the county. And I just want to share with you how inequitable both the incidence of diseases and inversely the number of tests that are being done are highest in the low positivity, higher socioeconomic communities, whereas the proportion of cases and the test positivity is higher in South and Southeast King County, where relatively fewer tests are being done. That's why we've opened up 4 community testing centers there in the last recent weeks. And these are the age-adjusted case hospitalization and death rates by race and ethnicity. White people are shown in blue here, light blue, and then Black, Hispanic, Asian, and not Native Hawaiian Pacific Islander. So these are cases, hospitalizations, disproportionately impacting Black, Hispanic, and Native Hawaiian Pacific Islanders, and then death rates comparable in white, Black, Asian, and American Indian Alaska Natives, but higher in Hispanic, Latinx, and Native Hawaiian Pacific Islanders. And I'm sure you've all heard about the disproportionate impact and the disparities, and I'm sure you're not surprised because we see the same health disparities in the same groups in the same parts of the county with respect to poor housing, tobacco use, frequent mental distress, adverse childhood experiences, and a host of other adverse health outcomes that are linked to the social determinants of health and the structural racism that exists in our society. Now, these are the types of exposures that people are getting that are leading to SARS-CoV-2 infection in our community. Right now, community-level exposures and out-of-state travel is responsible for over a third of cases. And these are social gatherings and get-togethers with families and friends, parties, recreation, weddings, celebrations, dining out, at bars, faith-based worships, large numbers of people coming together on Sundays and to do other Bible study and related activities, the Greek outbreak at the UW system, and then just leisure travel. In addition, essential workers, which are theoretically essential activities, are exposed to the virus, and then a large proportion in household secondary transmission. So this is what we're looking at now, the potential for Thanksgiving to be a community-wide super spreader event. This happened in British Columbia. Unfortunately, they've had a big spike after the Canadian Thanksgiving, and this is why I'm concerned. Utah's hospitals are preparing to ration care because of the magnitude of the spike in their state. And Denver hospitals are poised to surpass their large outbreak in April and are taking steps now to avoid becoming overwhelmed. And this is a projection from IHME at the University of Washington that shows us that by January, the number of ICU beds needed will exceed the number of available beds, and the number of all beds needed for COVID-19 patients will be about a quarter to a third of all of our hospital beds in the county if we don't get our outbreak under control. I'm now going to just finish up with talking a little bit about a couple of other issues, vaccines. So these are the COVID-19 vaccines in human clinical trials in the U.S. There are 2 mRNA vaccines that are the leading candidates, the Moderna and the Pfizer vaccines. And then there are a number of adenovirus vector vaccines and a protein subunit vaccine. This Novavax has also entered phase 3 any day now. So basically, the point here is that these are new vaccine platforms. I encourage you to learn a little bit about them so you can communicate with your patients. This could be the topic of an entire talk by itself. There are other vaccines in clinical trials in phase 1 and 2, and there are over 200 vaccines total in trials around the world. With respect to distribution, it's likely that there will be limited doses available, perhaps beginning as early as late this year. And these limited doses will be targeted to high-risk populations such as healthcare workers and first responders, and if supplies permit, people with high-risk conditions such as older adults and those living in long-term care facilities. And then as more doses become available, a tiered strategy will make the vaccine increasingly available to other populations. For example, non-healthcare critical workers, people who live in other congregate settings like jails, other older adults, and then finally younger adults, other critical workers, and then the entire population. Different formulations will become available at different times, and those formulations, their relative effectiveness and safety in different age groups, and their vaccine handling and storage requirements will help determine where they get targeted. And this is a very complex and evolving landscape. Some of these vaccines are 1, some are 2-dose series. As I said, varying formulations or presentations, different vaccine efficacy and safety profile in different populations are possible. Cold chain requirements vary. Their ability to be used in children and pregnant women may vary. Of course, we need to think about how to do socially distanced vaccination. Communication and education are going to be critical. And the high-risk groups for COVID-19, I would say, do distrust public health, and they do distrust the healthcare system. So that's another challenge in getting this outbreak under control. There's some really good information on the CDC website. I share this page with you, 10 things healthcare professionals need to know about COVID vaccination plans. I encourage you to take a peek at that. And I wanted to just share these challenges around pandemic response. I'm getting toward the close now, but there are a few areas here I came across in preparing this presentation. I came across this slide and I could not resist sharing it with you. So with respect to lab testing, limited supplies of commercial rapid tests, lack of a reliable point of care test, clinician reliance on the public health lab for management initially, public health lab being quickly overwhelmed, commercial labs not integrated into the public health response. Within the healthcare system, we've seen conflicting guidelines, outpatient sector unprepared and referring patients to ED, not wanting to care for these cases, hospitals with limited supplies of N95 masks and test kits, outpatient settings with shortage of PPE, failure of just-in-time purchasing and supply chains, and challenges with respect to the exclusion of exposed healthcare workers and implications for workforce, and then vaccine issues related to inappropriate expectations around protection and ending the pandemic, the communication issues around adverse events, unknown timing for receipt of vaccine, unknowns about what formulations and quantities of vaccine will be available, challenges reaching certain target populations, and allocation of limited supply. The reason I wanted to share this with you is because these are my lessons learned from the H1N1 2009 outbreak, not from COVID-19. And it really hit home to me how little we're able to accomplish in between outbreaks. And one of the reasons for that, I think, I'm going to share with you now, but this was the Global Health Security Index. This is a first ever national and international survey of bioemergency preparedness across all the countries of the world, and the U.S. came out number 1 with the overall score, and number 1 for prevention of emergence of release of pathogens and for early detection and reporting of epidemics, and number 2 for rapid response and mitigation to the spread of an epidemic. So we were rated the most prepared country in the world to deal with an emerging infectious disease outbreak. But as you all know, things didn't go so well for us, and there's a great piece in the viewpoint of JAMA by Jennifer Nuzzo from Hopkins. And basically, the bottom line is, we outranked all these other countries because we have more capacity, we have more stuff and fewer identified risks. But we were one of only a small number of high-income countries in the index that received the lowest possible score on public confidence in government. And we are seeing the consequences of that right now. how that undermines public's adherence with disease control measures and other compliance that's necessary for public safety. So we also received very low scores on important indicators around the strength of our healthcare system and the ability of our citizens to access healthcare. We ranked 175th globally due to the absence of universal healthcare coverage and large numbers of uninsured and underinsured people. This is the life expectancy in the U.S. on the bottom line compared to all of our Organization for Economic Cooperation and Development peers. We have the lowest life expectancy of any of them. And this is an example of the funding streams for public health and hospital preparedness over the last 20 years or so, where state and local public health emergency preparedness funding and hospital preparedness program funding has been eroded. I didn't get to talk at all about treatment, and that's really not what I focus on in my daily work right now, but I did want to make you aware of this great website at the NIH, which is very succinct treatment guidelines for clinicians about COVID-19, so you can take a look at that if you are treating patients. And with that, I will conclude my presentation. I hope we have a few minutes for Q&A. It's been a real pleasure to have this change of pace this morning, and I hope some of these comments were useful to you.
Jeff, thank you so much. I think lots of love out there for you.
Thank you. I could use it right now. I think we all can use it. We should have a group virtual hug.
Yeah. That's the only kind of hug we can have right now. What we're going to do, this obviously such an important issue for our members, for our communities, for our nation. And so what I'm going to do is we're going to take questions to 9 o'clock. And then we're going to have a little bit of shorter break this go around, because obviously there are a lot of questions out there, and I'll try and organize them for you. And so the first question, there's several questions, Jeff, around N95 masks. Is that important for healthcare workers? What if someone's infected in terms of trying to minimize transmission? What are your thoughts on N95s versus other masking versus other strategies?
Yeah, well, N95 is clearly important for aerosol generating procedures, intubations, other procedures, suctioning, and other things that, are going to generate those small particles. I would say that health agencies around the world are split on whether it's necessary for the care of COVID patients, confirmed or suspected COVID patients, in the absence of aerosol generating procedures. The CDC and NIOSH are very conservative, and they do recommend the N95 for any patient interaction. However, they acknowledge that and understand that just is not possible. There's not an unlimited supply that every healthcare worker can have an N95 for every interaction, and recommend the surgical mask and eye protection for that scenario. And that is what the World Health Organization, Canada, Australia, and most of our other peer nations recommend as well. But clearly, if there's any high-risk procedure going on, that's an aerosol-generating procedure, and those are defined on the CDC website, a list of them, but not all. N95 would be preferred.
Great. Jeff, several people upvoting this question around fomite transmission, surface contact, need for bleaching groceries. Where are we at with that?
Yeah, definitely no need for bleaching groceries. So it's likely that fomite transmission can occur, but it has never been documented. There are no cases of fomite transmission that have been reported. And, although there have been some studies under laboratory conditions and attempting to replicate real world conditions that show that the virus can live for a couple of days, particularly on smooth, hard surfaces, the implications for transmission are just not clear. It's thought to be a possible, a potential, but undocumented and of less significant mode. So we recommend hand washing and hand sanitizers to minimize that risk. It's certainly a possibility, but it's not thought to be, based on all available evidence, an important mode of transmission.
Great. You want to let's just tackle this. I'm going to change gears real quick back to the vaccine, but what are Washington State's thoughts on distribution of vaccine to healthcare workers? How do you see that coming down the pipe?
Yeah, so of course, we don't have a vaccine yet, so we don't really know, whether we'll have a safe and effective vaccine or the time. I think we will. We don't know the timing, but there are some guidelines in development based on input both from the National Academy of Medicine and then the Advisory Committee on Immunization Practices, ACIP. I'm very privileged to be able to sit on the ACIP's COVID-19 vaccine work group, and I'm very familiar with the guidance. There are slides posted on the ACIP meeting website now where you can see the most recent thinking about this. It's thought that the first vaccines made available will be the mRNA vaccines, and these require ultra cold storage, so it's only a few freezers in our whole county that can take this minus 80 temperature. And once these vaccines come out, they must be used in a rather quick time frame, and they're brought out in 500 dose pallets. So it's likely that the first vaccine administered will go to healthcare facilities that can store and go through that volume, and they will be pods of distribution for high-risk healthcare workers. And then as more vaccine becomes available, that can be administered in the community, vaccine will be rolled out into the community distribution locations. The precise tiering of risk groups is still under discussion, but it's likely to be healthcare workers and critical infrastructure, followed by the highest risk patients, and then progressively lower risk patients, and then the general public. There's a huge emphasis on equity and access to vaccines to those people who have been disproportionately impacted by COVID and who are suffering from the health disparities related to this outbreak and pre-existing health disparities. So our essential workers that are allowing us to keep our hospitals and every other facility running, our transit systems, and so on. These people, many of whom live in South King County, are of lower socioeconomic status. These are not high-paying jobs. The support workers in the healthcare facilities and the long-term care facilities, these folks are at highest risk of infection, much higher than physicians. They are putting their lives on the line every day, and we want to make sure that we get vaccine out to them if they choose to take it, which is the big unknown.
Jeff, that was well said. So one other, this is, I think, a good opportunity. We're heading into this Thanksgiving. You highlighted this. We'll take this one last question, and then we'll try and get Dr. Duchin to answer some of our other questions offline. But we have patients who are coming in to see us. They may have kids coming home or grandkids coming home for the holidays. What advice do you have around these Thanksgiving holidays for returning students? What do you recommend? Testing before campus, quarantining at home, retesting at home? How do we counsel our older patients who may plan their Thanksgiving holiday?
Yeah, this has the potential to be an explosive outbreak that will take down our healthcare system. So I urge you all to take this with the greatest amount of concern and as seriously as possible, and imploring your patients not to travel, to keep their Thanksgivings to the family only, to, if they must have people outside their household, make it small, and socially distance, wear masks, make sure they pay attention to ventilation to decrease the risk, make sure no one who has any symptoms or has been exposed to someone with COVID attends. So people who have been exposed to others should quarantine, and that's so challenging right now because we have so much COVID in our community. You don't even know if you've been exposed. There's so many people out there who have it. So it's very challenging, which is why we say, best not to gather. However, if it's going to happen, testing can be informative. The thing to know about testing is that it only tells you you're negative at the time of the test. Hours later, you can start to excrete virus. So the safest thing is to quarantine for 14 days and then test at the end of the 14 days and document being negative. quarantining for shorter periods and testing. Testing immediately before attending a gathering can be somewhat reassuring. Someone's negative and without symptoms, probably less risk, but again, not risk-free. So a combination of testing and quarantine can be useful, or just quarantine for 14 days away from others. But of course, the travel itself induces risk. So if someone's traveling, they could do their quarantine, but once they travel, they're re-exposed. So no matter how you look at it, it's going to be a high-risk situation. And I really would discourage people this year, not forever, not for the rest of our lives, but this year, from foregoing these family gatherings, especially right now where we're having record-breaking numbers of cases.
We'll get through it. So with your leadership. So thanks, Jeff. There's tons of questions. We'll try and tackle some more of those offline and put them up on the website. And I'm going to do a little foreshadowing for y'all. We'll have again an opportunity to show our love and appreciation for all the work that Dr. Duchin has done on behalf of our communities around the lunch hour. So make sure to stick around, and Jeff will see you later. So thank you. We're going to come back at 9:05, everybody. We'll start the next session at 9:05. You'll have a short social session, and then we'll do a longer one a little bit later.
Thanks, Matt. It's great to be here.
Yeah, glad that you're here.